How do you prioritize the assessment of a patient newly admitted from the CCU with chest pain?
When a patient is newly admitted from the CCU with chest pain, my priority is to ensure immediate safety, stabilize the patient, and identify any signs of deterioration early. I begin by conducting a rapid primary assessment focused on airway, breathing, and circulation, followed by a targeted cardiovascular assessment. I ensure continuous cardiac monitoring is connected, obtain a 12-lead ECG promptly, assess vital signs, pain characteristics, and review the transfer notes, medications, and previous cardiac history. A situation that demonstrates my approach occurred when I was working in a cardiac step-down unit where a 58-year-old post-PCI patient arrived from CCU reporting new onset chest tightness. My task was to determine whether this was benign post-procedural discomfort or a sign of acute ischemia. Within the first minute, I ensured oxygen was administered as clinically indicated, attached the patient to telemetry, and performed a focused assessment while simultaneously informing the senior nurse in charge. I completed a 12-lead ECG within 5 minutes and compared it with a baseline ECG from the CCU notes. The ECG showed subtle ST segment changes, so I escalated immediately to the on-call cardiology team and administered GTN as per protocol while maintaining close haemodynamic monitoring. I prepared the patient for potential urgent review, ensured 4 access was patent, repeated vital signs every 5 minutes, and reassure the patient throughout to reduce anxiety-induced sympathetic stress. As a result of rapid prioritization and early escalation, the medical team diagnosed evolving ischemia and the patient was transferred back to the cath lab within 20 minutes. The consultant later noted that timely assessment helped prevent significant myocardial damage. This experience reinforced my commitment to structured assessment, early recognition, and proactive communication in cardiac care.
Explain your approach to recognizing early signs of cardiac deterioration in a step-down environment.
Recognizing early signs of cardiac deterioration in a step-down environment requires vigilance, structured assessments, and an understanding that patients transitioning from critical care may still be clinically fragile. My approach combines continuous observation, early warning scoring systems, trend analysis, interdisciplinary communication, and a proactive attitude to escalation. Clinically, I closely monitor changes in vital signs, arrhythmias on telemetry, new chest discomfort, increased shortness of breath, reduced peripheral perfusion, altered mental status, or subtle signs like restlessness and new fatigue. I also pay attention to laboratory values such as rising troponins or potassium abnormalities and ensure any new deviation is analyzed in the context of the patient's overall pattern rather than as isolated data. A situation that reflects my approach involved a 72-year-old patient recovering from STEMI who appeared stable during morning rounds. My task was to continue monitoring and identify any early signs of deterioration. About 2 hours later, I noticed a slight but persistent drop in blood pressure, increased ectopic beats on telemetry, and the patient reporting a different kind of tiredness. Although the deterioration was subtle, I trusted the trend. I immediately conducted a focused cardiac and respiratory assessment, verified the telemetry rhythm with a 12-lead ECG, reassessed vital signs, and ensured 4 access remained patent. I contacted the medical registrar with specific data trends and my clinical concerns. While awaiting review, I placed the patient on continuous oxygen saturation monitoring, prepared emergency medications, and maintained calm communication with the patient to minimize anxiety. As a result, the registrar confirmed evolving cardiogenic compromise, likely early heart failure, and initiated diuretics and further investigations. Because deterioration was recognized early, the patient remained stable on the ward and avoided an emergency CCU transfer. This reinforced my belief that early recognition depends on vigilance, data interpretation, and never ignoring subtle changes.
What ECG changes would concern you the most in a post-PCI patient, and how would you respond?
In a post-PCI patient, the ECG findings that concern me most are those suggesting acute reocclusion or evolving ischemia, because these changes can precede rapid clinical deterioration. New or worsening ST segment elevation in the territory of the treated vessel is the most urgent red flag, especially if it is accompanied by reciprocal changes. I'm also highly alert to new ST depressions, deepening T-wave inversions, or recurrent ventricular arrhythmias such as VT or frequent multifocal PVCs, which may indicate myocardial irritability or compromised perfusion. Even subtle changes, such as loss of previously improved ST segments, can be clinically significant in the early post-PCI window. My response combines immediate assessment, structured escalation, and efficient coordination. First, I reassess the patient at the bedside, focusing on chest pain characteristics, haemodynamic stability, oxygenation, and overall appearance. Post-PCI patients often minimize symptoms, so I prioritize correlating objective changes with even mild or vague discomfort. I obtain a repeat 12-lead ECG without delay and review the rhythm strip to confirm the trend. If the changes persist or worsen, I treat the situation as a potential acute coronary event. I then escalate urgently to the cardiology team using a clear, concise SBAR handover, ensuring I communicate the exact ECG evolution, symptom onset, and any risk factors such as stent type, lesion complexity, or anticoagulation status. While awaiting medical review, I provide oxygen if indicated, ensure for access is patent, prepare for possible blood tests and analgesia, and closely monitor telemetry and vital signs. If the patient becomes unstable, I activate the rapid response team immediately. To illustrate, I once cared for a post-PCI patient whose ST segments began rising subtly an hour after the procedure. Although he denied significant pain, I escalated early, and cardiology arranged repeat angiography. He was found to have early stent thrombosis and received urgent intervention, preventing a major infarction. This experience reinforced that rapid recognition and assertive escalation of ECG changes can profoundly alter outcomes.
How do you differentiate cardiac chest pain from non-cardiac chest pain during your assessment?
Differentiating cardiac chest pain from non-cardiac causes is a critical component of safe nursing assessment, particularly in cardiac step-down environments where patients often present with complex comorbidities. My approach focuses on gathering a structured history, evaluating characteristics of the pain, and correlating these findings with objective assessments such as ECG, vital signs, and risk factors. Clinically, I start by asking the patient to describe the pain using a systematic framework: onset, location, duration, character, radiation, relieving or aggravating factors, and associated symptoms. Cardiac chest pain is often described as pressure or heaviness, sometimes radiating to the arm, jaw, back, or shoulder, and may be accompanied by diaphoresis, nausea, dyspnea, or palpitations. Non-cardiac pain may be localized, sharp, reproducible with palpation or position changes, or associated with gastrointestinal symptoms. I always combine subjective reports with objective findings, including telemetry changes, blood pressure fluctuations, oxygen saturation, and cardiac biomarkers. A scenario that reflects my approach involved a 64-year-old patient admitted with unstable angina who later reported sharp right-sided chest pain. My task was to determine whether this pain was cardiac in origin or secondary to another cause. During assessment, I noted that the pain was reproducible on palpation, worsened when the patient turned in bed, and had no radiation or associated symptoms. His ECG showed no new changes, and vital signs remained stable. To ensure accuracy, I repeated the assessment, reviewed medications, and considered musculoskeletal strain from repeated coughing due to mild postoperative atelectasis. I escalated to the medical team with a clear summary of findings, but also administered analgesia and repositioned the patient for comfort. The result was a confirmed diagnosis of musculoskeletal chest wall pain, avoiding unnecessary invasive investigations and reducing patient anxiety. This experience reinforced the importance of structured assessment, clinical reasoning, and correlating symptoms with objective trends to differentiate cardiac from non-cardiac chest pain safely.
Describe your experience interpreting rhythm strips and forming nursing actions based on your findings.
I have extensive experience interpreting rhythm strips in cardiac step-down and telemetry settings, and I understand how crucial timely interpretation is for preventing deterioration. My approach is to combine systematic ECG analysis with patient-centered assessment so that I correlate the rhythm with a clinical picture rather than treating the strip in isolation. I evaluate rate, rhythm regularity, P-wave visibility, PR interval consistency, QRS morphology, and presence of ectopics or ST changes. When abnormalities are identified, I prioritize patient safety by acting promptly, escalating early, and initiating appropriate interventions as per protocol. A situation that demonstrates this occurred when I was caring for a 70-year-old patient recovering from decompensated heart failure. My task was to monitor his rhythm closely because he had a history of atrial fibrillation with intermittent rapid ventricular response. During a routine telemetry review, I noticed a sudden switch from controlled AF to a run of wide complex tachycardia at 160 bpm. Although the patient initially said he felt fine, I recognized the seriousness of the rhythm and performed an immediate focused assessment. His blood pressure had begun to fall, he appeared slightly pale, and he reported new dizziness. I activated the clinical emergency protocol, placed the patient on continuous oxygen monitoring, ensured for access was patent, prepared emergency medications, and stayed with him until the medical registrar arrived. I provided a concise handover including strip interpretation, trends, symptoms, and recent medications such as diuretics that could have affected electrolytes. As a result of rapid identification and escalation, the patient received prompt pharmacological management and avoided progression to haemodynamic collapse. The cardiology team later confirmed that early recognition of ventricular tachycardia allowed timely intervention. This reinforced how critical it is not only to interpret rhythm strips accurately, but to link those findings with decisive, patient-centered nursing actions.
A patient's blood pressure drops from 128/76 to 92/58 within 15 minutes. What is your step-by-step response?
When a patient's blood pressure falls acutely from 128/76 to 92/58 within 15 minutes, my response is immediate, structured, and centered on rapid assessment, stabilization, and escalation. In a recent situation on our step-down unit, a post-op cardiac patient developed this exact drop, and my task was to rapidly identify the cause and prevent hemodynamic collapse. First, I performed a focused ABC assessment within the first minute, checked airway patency and the patient's work of breathing, assessed respiratory rate and oxygen saturation, and palpated a radial pulse to confirm rate and character. Simultaneously, I looked at the monitor to verify the reading was real, excluding artifact, retook manual BP in both arms, and observed skin color, capillary refill, and level of consciousness to judge perfusion. Having confirmed the hypotension was real and the patient felt lightheaded, I immediately lowered the head of the bed and placed the patient in Trendelenburg modified position to improve cerebral perfusion, administered oxygen, and ensured for access was patent. I reviewed recent medication chart and notes for recent boluses, epidural/top-ups, or antihypertensives that could explain the drop and asked a second nurse to draw bloods, full blood count, electrolytes, lactate, troponin, and sent a stat ECG to assess for arrhythmia or ischemia. While the other nurse brought emergency fluids, I prepared a 500 milliliters crystalloid bolus and discussed with the registrar the need for vasopressor support if fluids did not restore pressure. I informed the rapid response team and gave a concise SBAR handover, including baseline vitals, trend, medications, and interventions already given. As a result of these coordinated steps, verification, positioning, oxygen, fluid bolus, and escalation, the patient's blood pressure improved to 110/70 within 20 minutes and perfusion normalized. The medical team identified transient vasodilation from a recent opioid bolus as the likely cause. We adjusted analgesia and continued close observation. This episode reinforced that rapid, evidence-based steps, clear communication, and teamwork are essential to manage acute hypotension safely.
What complications do you watch for in patients with transvenous or external pacing leads?
In patients with transvenous or external pacing leads, I remain highly vigilant because these patients are at risk of sudden deterioration if complications occur. My priority is to monitor for lead displacement, loss of capture or sensing, infection at the insertion site, tamponade, arrhythmias, bleeding, and electrical malfunctions. I assess pacing thresholds, monitor the ECG for spikes and corresponding QRS complexes, evaluate hemodynamic stability, and ensure that the external generator is secure, functioning, and appropriately set. I also check the insertion site for erythema, bleeding, swelling, or signs of migration, while continuously reinforcing patient education about limiting arm movement to reduce lead displacement risk. A situation that illustrates my approach occurred when caring for a 66-year-old patient with a temporary transvenous pacer following complete heart block. My task was to maintain close surveillance because the patient was only 48 hours post-insertion. During a routine shift assessment, I noticed the pacing spikes on telemetry were no longer consistently followed by QRS complexes, and the patient appeared increasingly fatigued and mildly hypotensive. Recognizing the possibility of loss of capture, I immediately performed a focused cardiovascular assessment, verified the connection integrity between the lead and external generator, and checked that the rate, output, and sensitivity settings had not been accidentally altered. I escalated immediately to the cardiology registrar, provided a precise summary of rhythm changes and symptoms, and prepared the patient for potential lead repositioning. While awaiting review, I applied oxygen, ensured for access was patent, minimized patient movement, and kept emergency equipment readily available. The registrar confirmed lead displacement, which required urgent adjustment. As a result of rapid recognition and escalation, the patient avoided further hemodynamic compromise and stabilized quickly after lead repositioning. This experience reinforced the importance of continuous monitoring, correlating electrical activity with clinical presentation, and acting decisively at the first sign of pacing complications.
How do you manage a patient with a newly initiated inotrope infusion in a step-down unit?
Managing a patient with a newly initiated inotrope infusion requires heightened vigilance, precise monitoring, and seamless communication with a medical team. My priority is to ensure hemodynamic stability, maintain infusion accuracy, and identify early signs of deterioration or adverse effects. I begin by reviewing the indication, prescribed dose, titration parameters, and expected physiological response. I ensure the infusion is connected via a dedicated lumen on a central line or appropriately positioned large-bore peripheral line if clinically permitted, using an infusion pump with exact settings. A situation that shows my approach involved a 74-year-old patient who had just been stepped down from CCU with a newly commenced low-dose dobutamine infusion for cardiogenic fatigue. My task was to monitor his response and maintain safety during the first hour of transfer. I started with a focused baseline assessment, vital signs, MAP, urine output, mental status, peripheral perfusion, and rhythm analysis, followed by validating the infusion pump settings and confirming line patency. Within 30 minutes, I noticed his heart rate increasing from 82 to 108 BPM and MAP dropping slightly. Recognizing this as a potential early adverse effect, I performed a repeat assessment, verified the pump rate, checked for extravasation, and immediately notified the medical registrar with clear trend data. While awaiting review, I reduced environmental stimulation, maintained oxygen therapy, repositioned the patient to optimize preload, ensured accurate documentation of minute-to-minute changes, and prepared emergency medications. The registrar adjusted the dobutamine dose and ordered blood gases to reassess perfusion. As a direct result of early detection and rapid escalation, the patient stabilized without requiring CCU transfer, and his infusion was titrated safely over the next hours. This experience reinforced that managing inotropes in a step-down unit requires structured assessment, precise titration, early recognition of subtle adverse trends, and proactive multidisciplinary collaboration.
What are your priority assessments for a patient returning from cardiac catheterization?
When caring for a patient returning from cardiac catheterization, my priority assessments focus on hemodynamic stability, puncture site integrity, vascular perfusion, and early identification of post-procedure complications such as bleeding, hematoma, arrhythmias, contrast reactions, or renal impairment. I begin with a full set of vital signs, continuous rhythm monitoring, pain assessment, and evaluation of mental status. I then assess the access site, radial or femoral, for bleeding, swelling, firmness, or oozing, and ensure pressure dressings remain intact. Distal circulation checks are essential, including pulses, color, warmth, and capillary refill. I also monitor urine output to assess renal function following contrast use and encourage oral hydration if appropriate. A situation demonstrating my approach involved a 61-year-old patient who had undergone a femoral access PCI and returned to the step-down unit for post-procedure monitoring. My task was to ensure early detection of vascular or hemodynamic complications. Within 20 minutes of arrival, while performing the second set of vital signs, I noticed the patient complaining of new lower back discomfort and increasing anxiety, symptoms not typical for routine recovery. On inspection, the femoral dressing appeared intact, but I palpated a firm expanding mass above the puncture site and saw a subtle drop in blood pressure from 132/78 to 108/70. Recognizing these as early signs of a developing retroperitoneal bleed, I immediately applied manual pressure to the site, called for assistance, placed the patient in a supine position, and initiated high-flow oxygen. I notified the interventional cardiology team urgently with clear SBAR communication, established 2 large-bore 4 lines, and prepared for fluid resuscitation. As a result of rapid assessment and escalation, the patient was promptly taken back to the cath lab for intervention, preventing further hemodynamic deterioration. This reinforced my commitment to structured assessment, vigilance, and early action in post-catheterization care.
Describe the nursing care of a patient post-CAB who has been stepped down.
Caring for a patient who has been stepped down after CAB requires a holistic, structured approach that balances hemodynamic stability, respiratory optimization, wound care, mobility progression, pain control, and psychosocial support. My priority is to stabilize the transition from critical care by performing a comprehensive assessment that includes vital signs, rhythm monitoring, chest drain status if still present, oxygenation, peripheral perfusion, surgical site integrity, fluid balance, and early signs of complications such as arrhythmias, atelectasis, bleeding, infection, or graft failure. I also ensure effective analgesia so the patient can mobilize and perform respiratory exercises safely, reducing pulmonary complications. A situation that illustrates my approach involved a 69-year-old patient stepped down 24 hours post-CAB. My task was to support recovery while identifying complications early. During initial assessment, I noted shallow breathing, moderate incisional pain, and reduced air entry at the bases. Although vitals were stable, I recognized the risk of atelectasis. I administered scheduled analgesia, educated the patient on splinting the sternum during coughing, and supervised intensive spirometry every hour. I collaborated with physiotherapy to initiate safe mobilization and monitored telemetry closely for postoperative atrial fibrillation. For hours later, the patient developed an irregular rhythm with a heart rate in the 130s. I immediately confirmed this on a 12-lead ECG as new-onset AF, assessed hemodynamic stability, ensured electrolytes were reviewed, and escalated to the registrar with a precise trend summary. The patient required rate control medication, which stabilized his rhythm. As a result of timely assessment, coordinated care, and proactive intervention, the patient was able to continue recovery on the ward without returning to critical care. This experience reinforced the importance of structured observation, early mobilization, respiratory support, pain optimization, and rapid response to postoperative arrhythmias in CAB step-down nursing.
What complications must be monitored in patients post-ablation for AF or SVT?
Patients recovering from AF or SVT ablation require close monitoring because they remain at risk for several early and potentially serious complications. My priority assessments focus on vascular complications at the access site, arrhythmia recurrence, pericardial effusion leading to tamponade, thromboembolic events, bleeding, infection, and post-procedure chest discomfort from myocardial irritation. I begin with frequent vital signs, continuous rhythm monitoring, pain assessment, and evaluation of hemodynamic stability. I carefully inspect the groin or radial access site for bleeding, hematoma, firmness, or swelling, and assess distal pulses and limb color. I remain vigilant for signs of tamponade such as hypotension, tachycardia, jugular venous distension, muffled heart sounds, or sudden dyspnea. In addition, I observe neurological changes that may indicate embolic events, and I ensure that anticoagulation, if indicated, is managed safely. A situation that reflects my approach occurred with a 55-year-old patient who had undergone ablation for paroxysmal AF. My task was to provide safe early recovery monitoring on the step-down unit. During the second post-procedure set of observations, I noticed the patient becoming increasingly breathless and reporting new chest heaviness. His heart rate was rising into the 110s, blood pressure trending downward, and telemetry showed electrical alternates. Recognizing these as potential early signs of pericardial effusion, I immediately performed a focused cardiovascular assessment, notified the cardiology registrar, and placed the patient on oxygen while positioning him to optimize venous return. I prepared emergency equipment, ensured 4 access was patent, and continued to monitor vital signs every 5 minutes. The registrar confirmed a developing pericardial effusion, and the patient was transferred directly to the cath lab for urgent pericardiocentesis. Because the deterioration was recognized early, he remained clinically stable and avoided cardiac arrest. This experience reinforced the importance of structured assessments, recognizing subtle post-ablation red flags, and escalating promptly to prevent serious complications.
How would you recognize and manage a hematoma at a femoral access site?
Recognizing and managing a hematoma at a femoral access site requires vigilance, structured vascular assessment, and rapid intervention to prevent progression to retroperitoneal bleeding or hemodynamic instability. My approach is to begin with frequent inspection and palpation of the puncture site, noting firmness, swelling, warmth, or changes in size. I also assess distal pulses, limb temperature, color, and capillary refill, as well as monitoring vital signs for early indications of bleeding such as rising heart rate, falling blood pressure, or new patient-reported back or abdominal discomfort. A situation that reflects my practice occurred when caring for a 63-year-old patient returning from a diagnostic left heart catheterization. My task was to complete the first post-procedure assessments and detect any vascular complications early. During the second set of observations, approximately 30 minutes after arrival, I noted a small but rapidly firming lump just above the femoral dressing. The patient also reported new groin pressure and mild anxiety. Recognizing these as early signs of a developing hematoma, I immediately applied firm manual pressure to the area, asked a colleague to bring additional equipment, and placed the patient in a flat position to reduce arterial pressure at the site. While maintaining pressure, I reassessed vital signs and observed a slight drop in systolic blood pressure. I notified the cardiology registrar using SBAR, clearly describing the size and characteristics of the hematoma, the patient's symptoms, and the interventions already initiated. I maintained pressure until medical review, prepared for access for potential fluid resuscitation, and ensured continuous rhythm and hemodynamic monitoring. As a result of rapid recognition and immediate action, the hematoma was controlled, and the patient did not progress to retroperitoneal bleeding. He remained stable and continued his recovery uneventfully. This experience reinforced the importance of close observation, confident early intervention, and prompt escalation when managing femoral access complications.
Tell us about a time you initiated a rapid response due to cardiac changes. What was your decision-making process?
A situation in which I initiated a rapid response due to cardiac changes occurred when I was caring for a 71-year-old patient admitted with decompensated heart failure. My task was to monitor his rhythm and hemodynamic status closely because he had a history of paroxysmal AF and mild renal impairment. During the afternoon medication round, I noticed an abrupt rhythm change on telemetry from sinus rhythm to a wide complex tachycardia at around 150 beats per minute. The patient reported feeling suddenly unwell, with new dizziness and pressure across his chest. His blood pressure had dropped from 118/72 to 94/60 within minutes. Recognizing these as red flags for unstable ventricular tachycardia, I immediately performed a focused ABC assessment, confirmed the rhythm on a 12-lead ECG, and reassessed perfusion indicators such as skin color, temperature, and capillary refill. Concurrently, I verified for patency, placed the patient on high-flow oxygen, and instructed a colleague to bring the emergency trolley to the bedside. My decision-making process was guided by several factors: the sudden rhythm change, the drop in blood pressure, the patient's symptomatic deterioration, and the high likelihood of hemodynamic collapse without urgent intervention. Because these met the criteria for acute deterioration, I activated the rapid response team without delay and provided a concise SBR handover on their arrival, including rhythm strips, vital sign trends, medications administered that day, and the onset of symptoms. As a result of early recognition and rapid escalation, the team initiated antiarrhythmic therapy promptly, avoiding the need for advanced resuscitation. The patient stabilized within minutes and was transferred to CCU for closer monitoring. This experience reinforced the importance of trusting clinical judgment, recognizing early cardiac deterioration, and initiating rapid response promptly, even if the patient appears only mildly symptomatic, because early action can prevent cardiac arrest.
What is your immediate action when you discover a patient in sustained VT on the monitor?
When I discover a patient with sustained ventricular tachycardia on the monitor, my immediate action is to assess the patient first, because treatment depends on hemodynamic stability. I move straight to the bedside and perform a rapid ABC assessment within seconds, checking consciousness, airway patency, breathing effort, pulse presence, skin perfusion, and blood pressure, while simultaneously confirming the rhythm on the monitor and obtaining a 12-lead ECG if time allows. A situation that illustrates this occurred when I was caring for a 67-year-old patient admitted for acute heart failure optimization. My task was ongoing rhythm monitoring because he had a history of ischemic cardiomyopathy. During an afternoon safety round, the monitor alarmed, showing sustained VT at around 160 BPM. I immediately assessed the patient and found him pale and clammy, with a thready radial pulse and systolic BP of 86 millimeters of mercury. He reported feeling very dizzy and about to faint. Recognizing this as unstable VT, I knew immediate escalation was essential. I pressed the emergency call bell, instructed a colleague to bring the resuscitation trolley, and placed the patient on high-flow oxygen. I ensured floor access was intact, positioned the patient supine to maximize cerebral perfusion, and discontinued any medications that could worsen hypotension. While awaiting the rapid response team, I prepared defibrillation/pacing pads, attached them to the patient, and kept constant verbal reassurance to reduce sympathetic stress. I provided a concise SBAR handover to the team on arrival, including rhythm strips, vital sign trends, symptoms, medications, and the exact time VT was first detected. As a direct result of immediate recognition and preparation, the team performed synchronized cardioversion rapidly and restored sinus rhythm. The patient stabilized and was transferred to CCU for further management. This experience reinforced that immediate patient assessment, rapid escalation, and preparation for advanced interventions are crucial when confronted with sustained VT.
How do you manage a patient who suddenly becomes hypotensive and diaphoretic?
When a patient suddenly becomes hypotensive and diaphoretic, my approach is rapid, structured, and prioritizes stabilization while identifying the underlying cause. I immediately conduct an ABC assessment, verify the blood pressure reading manually to rule out artifact, and assess perfusion indicators such as skin color, temperature, capillary refill, mental status, and heart rhythm. At the same time, I initiate urgent interventions, positioning the patient flat or in modified Trendelenburg, administering oxygen, ensuring floor access is patent, and preparing for fluid resuscitation, while escalating to the medical team or activating a rapid response if indicated. A situation where I applied this process occurred when caring for a 73-year-old patient admitted with acute coronary syndrome. My task was routine monitoring, but during an evening assessment, he became suddenly sweaty, pale, and restless. His BP had dropped from 126/74 to 88/54, and telemetry showed increasing ventricular ectopy. Recognizing the seriousness, I went straight into a focused assessment. He was alert but anxious, with cool extremities and weak peripheral pulses. I manually confirmed the hypotension, repositioned him to improve venous return, and placed him on high-flow oxygen. Next, I ensured both 4 lines were patent and initiated a fluid bolus as per protocol. At the same time, I notified the registrar using SBR and requested immediate review. Anticipating potential cardiogenic compromise, I obtained a 12-lead ECG, checked for bleeding or signs of sepsis, and asked a colleague to draw urgent bloods including lactate and cardiac markers. I stayed with the patient, reassessing vital signs every 2 to 3 minutes and offering reassurance to minimize sympathetic strain. As a result of prompt recognition and coordinated action, the registrar arrived within minutes, diagnosed evolving cardiogenic shock, and commenced inotropic support. Early intervention prevented further deterioration, and the patient was transferred to CCU for advanced management. This experience reinforced that sudden hypotension paired with diaphoresis requires immediate assessment, rapid stabilization, and proactive escalation to ensure patient safety.
Explain your role during a code situation on the step-down unit.
In a cardiac step-down environment, my role during a code is to respond immediately, act within my scope, and support the code team to ensure rapid, coordinated resuscitation. First, I activate the code using the hospital emergency response system and quickly assess responsiveness, airway, breathing, and pulse. If the patient is pulseless or not breathing adequately, I begin high-quality CPR without delay, ensuring correct depth, rate, recoil, and minimal interruptions. While performing CPR, or once relieved by another trained staff member, I provide critical background information to the arriving code team, including the patient's rhythm history, recent vitals and trends, medications, especially antiarrhythmics, vasopressors, anticoagulants, and events leading up to the deterioration. I also take responsibility for establishing or maintaining 4/IO access, preparing emergency medications as directed, attaching the defibrillator pads, and assisting with rhythm analysis and defibrillation or cardioversion when ordered. Throughout the event, I ensure closed-loop communication, repeat orders for clarity, and document interventions according to policy. I coordinate with another nurse to manage the environment, clearing the area, ensuring suction and oxygen are ready, bringing the crash cart, and directing additional staff as needed. If family is nearby, I ensure they are supported and informed according to hospital policy, often asking another team member to be with them. After return of spontaneous circulation (ROSC), I help stabilize the patient with postcode care, continuous monitoring, reassessment of airway and hemodynamics, timely labs, and preparation for transfer to ICU. I also participate in the debriefing to identify what went well and opportunities for improvement. Overall, my role is to provide rapid, evidence-based, team-oriented support to maximize the patient's chance of survival and recovery.
How do you educate patients on lifestyle modification after an ACS event?
When educating a patient after an ACS event, I focus on providing clear, personalized, and evidence-based guidance that supports long-term secondary prevention. I always begin by assessing what the patient already understands about their diagnosis, their cultural and social context, and their readiness to learn. This helps me tailor the education to their specific risk factors, such as smoking, hypertension, diabetes, or stress. I explain in simple, reassuring language what happened during their ACS event and why lifestyle modification plays a central role in preventing future episodes. I then guide the patient through the key components of heart-healthy living by discussing smoking cessation, diet, activity, and medication adherence as interconnected parts of their recovery. For example, when discussing diet, I emphasize gradual, sustainable shifts toward a Mediterranean-style pattern and reduced intake of saturated fat, salt, and processed foods. With physical activity, I highlight the importance of safe, progressive exercise and reinforce how cardiac rehabilitation can significantly improve outcomes. I also help them understand how controlling their blood pressure, lipids, and glucose through medication adherence and routine monitoring reduces strain on the heart and prevents recurrent ischemic events. Stress management is addressed as a vital part of recovery, and I explore practical strategies such as improving sleep, mindfulness practices, and, when appropriate, referral to counseling. Throughout the education process, I use teach-back to confirm understanding and involve family members if the patient is comfortable, as this often improves adherence and confidence. Before discharge, I provide clear written information and ensure the patient knows how to reach the care team if questions arise. Ultimately, my goal is to empower the patient with realistic, achievable lifestyle strategies and to reinforce that even small, consistent changes can make a significant difference in their long-term cardiac health.
What key discharge instructions do you provide for a patient going home on beta blockers or anticoagulants?
When discharging a patient prescribed beta blockers or anticoagulants, I focus on ensuring they fully understand the purpose of the medication, how to take it safely, and the signs that require urgent attention. I begin by explaining in simple, patient-friendly terms why the medication is necessary. For example, how beta blockers help reduce cardiac workload and prevent arrhythmias, or how anticoagulants reduce the risk of thromboembolic events. I then review the exact dosing schedule, emphasizing consistency and the importance of not stopping the medication abruptly, as this may lead to rebound tachycardia or increased clotting risk. I place strong emphasis on recognizing side effects. With beta blockers, I educate the patient about potential dizziness, fatigue, or bradycardia, and I advise them to rise slowly from bed or chairs to prevent orthostatic hypotension. I reinforce that they should report symptoms such as extreme tiredness, breathlessness, or heart rate abnormalities. For anticoagulants, I explain the increased bleeding risk and guide them on practical safety measures, such as using soft bristle toothbrushes, avoiding contact sports, and monitoring for unusual bruising, black stools, nosebleeds, or prolonged bleeding from minor cuts. I ensure they understand the seriousness of signs like severe headaches or sudden weakness, which may indicate internal bleeding and require immediate medical attention. Additionally, I review interactions with other medications, over-the-counter product, and diet. For instance, if the patient is on warfarin, I teach them to keep their vitamin K intake consistent and to attend regular INR monitoring appointments. I finish by confirming their follow-up schedule, using TeachBack to ensure understanding, and providing written information for reference at home. My aim is to empower the patient with knowledge that supports safe medication use, prevents complications, and promotes confidence as they transition from hospital to home.
Explain how you would teach a patient to recognize early symptoms of heart failure decompensation.
When educating a patient about recognizing early symptoms of heart failure decompensation, my goal is to build their confidence in identifying subtle changes before they escalate into an acute episode. I start by assessing their current understanding and any previous experiences with fluid overload or breathlessness, as this helps me tailor the conversation to what is most relevant and less overwhelming. I explain that heart failure decompensation rarely occurs suddenly. Instead, it usually begins with small but important warning signs that the patient can detect early if they know what to look for. I focus on helping them recognize increasing shortness of breath, especially during routine activities or when lying flat. I explain why breathlessness occurs, reinforcing the importance of reporting changes early rather than waiting until it becomes severe. I teach them to monitor their weight daily at the same time each morning, using the same scale, and to inform the care team if they gain more than 2 kilograms within 2 to 3 days, as this often indicates fluid retention even before swelling appears. I also discuss peripheral signs such as ankle or abdominal swelling, tightening of rings or clothing, and a feeling of bloating or early satiety, all of which suggest worsening congestion. In addition to fluid-related symptoms, I cover systemic signs such as increasing fatigue, reduced exercise tolerance, palpitations, dizziness, and new or worsening cough. I explain that these may indicate changes in cardiac output or pulmonary congestion. Throughout the discussion, I use simple analogies, visual aids when available, and the TeachBack method to confirm understanding. Before discharge, I ensure the patient has written guidance, understands their target weight, knows their medication purpose and adherence importance, and has clear instructions on when and how to seek urgent help. My priority is to empower the patient to feel safe, informed, and proactive in managing their condition.
How do you communicate subtle but concerning cardiac findings to the cardiology team?
When communicating subtle but clinically significant cardiac findings to the cardiology team, I aim to be concise, structured, and evidence-focused so that the receiving clinician can make timely decisions. My approach is rooted in early recognition, clear articulation of the clinical picture, and accurate presentation of objective data. I begin by reassessing the patient thoroughly to ensure that the information I present is complete and current. For example, if I notice a gradual rise in ectopic beats, a new borderline ST segment change, or a trend of softening blood pressure, I immediately gather supporting parameters such as rhythm strips, vital sign trends, pain scores, oxygen requirements, and any changes in symptoms such as chest discomfort, dyspnea, or dizziness. I then contact the cardiology team directly rather than waiting for routine rounds because subtle changes often precede clinical deterioration. I use a structured communication framework such as SBAR to maintain clarity and ensure nothing is missed. I summarize the situation, outline relevant background, including comorbidities or recent interventions, and present the assessment with objective data such as telemetry strips, serial observations, and any bedside tests performed. I also include my professional concerns, even if the findings appear borderline, because cardiology teams consistently emphasize the value of early alerts. In the final part of the conversation, I outline what I have initiated, such as increasing monitoring frequency, repeating vitals sooner, ensuring for access, or reassessing pain. I then ask for specific guidance, such as whether they would like further investigations, medication adjustments, or early review. After the update, I document the discussion clearly, continue close monitoring, and escalate again if the patient's status changes. My overall priority is to ensure that subtle abnormalities are recognized early, communicated accurately, and acted upon promptly to prevent avoidable deterioration.
Describe a situation where you advocated for your patient based on cardiac assessment findings.
One situation that clearly reflects my commitment to patient advocacy occurred during my time in a busy cardiac step-down unit. A middle-aged patient recovering from ischemia had been stable for most of the shift, but during my routine assessment, I noticed very subtle changes. His heart rate, previously in the low 70s, had trended upward into the high 90s over 2 hours. He reported a vague sense of pressure in his upper chest that he felt was just indigestion, and his telemetry showed new, intermittent T-wave inversions that were not present earlier. Although his vital signs were technically within acceptable ranges, the combination of symptoms and ECG changes concerned me because I recognized the potential for evolving ischemia. My task was to ensure the patient received timely review despite the fact that he minimized his symptoms and the unit was managing multiple acute admissions. I first reassessed him thoroughly, obtained repeat vitals, and performed another rhythm strip, which confirmed subtle but consistent changes. I also evaluated other contributing factors, such as anxiety or musculoskeletal pain, to ensure my assessment was well-rounded. Once confident in my findings, I contacted the cardiology registrar directly, presenting a clear summary of the trends and expressing my concern that the changes could represent early ischemic deterioration rather than benign discomfort. My advocacy resulted in prompt medical review, repeat ECGs, and urgent blood tests, including serial troponins. Within a couple of hours, his troponin level showed a significant rise, prompting escalation of therapy and transfer back to the coronary care unit for closer monitoring and optimization of treatment. The cardiologist later acknowledged that the early notification allowed intervention before the patient deteriorated further. This experience reinforced the importance of trusting clinical judgment, recognizing subtle cardiac cues, and advocating assertively even when the situation appears borderline. It affirmed that proactive nursing vigilance can directly prevent harm and improve patient outcomes.
How do you support anxious patients who have had recurrent arrhythmias or chest pain episodes?
Supporting anxious patients with recurrent arrhythmias or chest pain requires a balance of clinical vigilance and emotional reassurance. I begin by acknowledging their fear without minimizing it, because many patients who have experienced unpredictable cardiac events feel a loss of control. I first ensure their immediate safety by conducting a focused assessment, checking rhythm strips, vital signs, pain characteristics, and any associated symptoms. Once I confirm there is no acute deterioration, I shift my attention to helping them manage the psychological impact of their condition. My approach involves creating a calm, unhurried space for the patient to express their concerns. I normalize their anxiety by explaining why these feelings are common after recurrent cardiac symptoms, especially when each episode triggers fear of another major event. I use simple, honest explanations about what their specific arrhythmia or chest pain pattern typically means, reinforcing the difference between benign episodes and warning signs that require urgent escalation. This helps patients distinguish routine symptoms from dangerous ones, reducing unnecessary fear while keeping them informed. I guide them through practical coping strategies such as paced breathing, grounding techniques, and gradual exposure to normal activities that may have become fear-provoking. For example, I have supported patients who were afraid to walk to the bathroom after multiple arrhythmia episodes. By accompanying them initially and monitoring their response, I help them rebuild confidence. I also involve the patient in their care by explaining telemetry findings in a way they can understand, which often reduces the uncertainty that drives anxiety. Before leaving the bedside, I ensure they know how to reach me, when to call for help, and what symptoms truly warrant concern. If anxiety persists or affects their recovery, I advocate for psychosocial support or cardiac rehabilitation referrals. My overall priority is to create a sense of safety, empower them with knowledge, and help restore trust in their body during recovery.
What makes cardiac step-down nursing different from general medical surgical nursing?
Cardiac step-down nursing is distinct from general medical surgical nursing because it requires a deeper level of clinical vigilance, specialized cardiac knowledge, and rapid decision-making in an environment where patients remain physiologically fragile despite being outside of critical care. In a medical or surgical setting, patients are often recovering from conditions with more predictable trajectories. In contrast, cardiac step-down patients may appear stable but can deteriorate quickly due to arrhythmias, ischemia, haemodynamic changes, or complications from interventions such as PCI, ablations, or pacing therapies. This creates a unique responsibility for nurses to detect very early, often subtle shifts in clinical status before they escalate into emergencies. Monitoring is more intensive in cardiac step-down, with nurses expected to interpret rhythm strips, recognize evolving ECG abnormalities, understand the implications of fluctuating blood pressure trends, and correlate subjective symptoms such as chest discomfort or breathlessness with underlying pathophysiology. Patients on step-down may also have complex therapies including inotropes, antiarrhythmic infusions, continuous heparin, or external pacing support. Safely managing these interventions requires strong assessment skills, precise medication knowledge, and confidence in escalating concerns promptly. Another key difference is the emotional dimension. Many cardiac patients have recently experienced life-threatening events such as ACS or arrhythmias, and they carry significant anxiety and uncertainty. Step-down nurses play an important role in psychological support, education on lifestyle modification, and preparation for long-term self-management, all while maintaining strict clinical oversight. Finally, cardiac step-down nursing demands close multidisciplinary collaboration. Nurses frequently communicate nuanced or borderline findings to cardiology teams, contribute to goal-directed care planning, and advocate for timely interventions. Overall, the setting requires a blend of acute care competencies, specialized cardiac expertise, and strong communication skills, making it more intensive, dynamic, and predictive than general medical, surgical nursing.
How do you prioritize care when managing multiple unstable cardiac patients?
When managing several unstable cardiac patients, my priority is to maintain safety through structured clinical judgment, continuous reassessment, and clear communication. I approach this by quickly identifying which patient faces the highest immediate physiological risk, because cardiac deterioration often progresses rapidly if subtle cues are overlooked. I begin by performing a brief but focused reassessment of each unstable patient, looking at arrhythmia severity, haemodynamic stability, symptom progression, and any red flags such as new chest pain, hypotension, sustained tachyarrhythmias, or oxygen desaturation. This helps me determine who requires immediate intervention and who can safely wait a few minutes. To illustrate, during one high-acuity shift, I was responsible for 3 step-down cardiac patients showing instability, one with new-onset atrial fibrillation with RVR, one with post-PCI chest pain, and one with dropping blood pressure after diuresis. My task was to maintain safe care without delay for any of them. I first assessed the post-PCI patient because chest pain in that context can indicate an acute reocclusion. While initiating an urgent ECG and notifying the cardiology registrar, I ensured that another nurse was aware of the AF patient so continuous monitoring could continue. Once the PCI patient was being reviewed, I turned to the hypotensive patient, reassessed fluid status, elevated the legs, repeated observations, and prepared for possible medication adjustments. Finally, I managed the AF patient by obtaining a rhythm strip, assessing perfusion, and preparing for rate control therapy as per protocol. Throughout this process, I communicated clearly with my team so that tasks were safely delegated rather than delayed. The result was that all 3 patients received timely interventions without deterioration. The PCI patient was transferred for repeat imaging, the hypotensive patient stabilized with medication adjustments, and the AF patient was successfully rate controlled. This experience reinforced that effective prioritization relies on rapid assessment, teamwork, anticipation of risk, and maintaining calm, structured decision-making under pressure.
How do you maintain competency in ECG interpretation, emergency management, and medication titration?
Maintaining competency in these high-risk cardiac skills requires continuous, intentional practice and a commitment to lifelong learning. I view ECG interpretation, emergency management, and titration of cardiac medications as areas where proficiency can never be static because new evidence, protocols, and clinical patterns continue to evolve. To stay current, I deliberately combine formal training, routine clinical exposure, and reflective practice. For ECG interpretation, I set aside regular time each week to review rhythm strips, 12-lead ECGs, and case studies. I use both real clinical tracings from my unit and structured learning resources to ensure I encounter a wide range of presentations, from benign ectopy to subtle ischemic changes. In practice, I make a conscious effort to interpret rhythm strips independently before confirming with senior colleagues or cardiology, because this reinforces pattern recognition and builds confidence. I also participate in ECG-focused workshops and simulation sessions whenever available. Emergency management is an area I maintain through frequent simulation, debriefing, and involvement in actual rapid response situations. I seek opportunities to take active roles during codes such as airway support, CPR leadership, or medication preparation because hands-on experience strengthens muscle memory. After every emergency, I take time to debrief, reflect on my performance, and identify areas for improvement. This reflective cycle helps ensure that my decision-making remains sharp under pressure. For medication titration, especially with inotropes, antiarrhythmics, and vasoactive agents, I stay familiar with current guidelines, pharmacodynamics, and unit-specific protocols. I review updates from cardiology, attend pharmacist-led teaching sessions, and regularly discuss dose adjustments with the medical team to deepen my understanding. Each time I titrate a medication, I mentally link the action to the patient's hemodynamic response, reinforcing clinical reasoning. Overall, I maintain competency by staying curious, actively seeking learning opportunities, and ensuring that every clinical episode becomes a chance to refine my practice.
What qualities do you think are essential for a cardiac step-down nurse?
Maintaining competency in these high-risk cardiac skills requires continuous, intentional practice and a commitment to lifelong learning. I view ECG interpretation, emergency management, and titration of cardiac medications as areas where proficiency can never be static because new evidence, protocols, and clinical patterns continue to evolve. To stay current, I deliberately combine formal training, routine clinical exposure, and reflective practice. For ECG interpretation, I set aside regular time each week to review rhythm strips, 12-lead ECGs, and case studies. I use both real clinical tracings from my unit and structured learning resources to ensure I encounter a wide range of presentations, from benign ectopy to subtle ischemic changes. In practice, I make a conscious effort to interpret rhythm strips independently before confirming with senior colleagues or cardiology, because this reinforces pattern recognition and builds confidence. I also participate in ECG-focused workshops and simulation sessions whenever available. Emergency management is an area I maintain through frequent simulation, debriefing, and involvement in actual rapid response situations. I seek opportunities to take active roles during codes such as airway support, CPR leadership, or medication preparation because hands-on experience strengthens muscle memory. After every emergency, I take time to debrief, reflect on my performance, and identify areas for improvement. This reflective cycle helps ensure that my decision-making remains sharp under pressure. For medication titration, especially with inotropes, antiarrhythmics, and vasoactive agents, I stay familiar with current guidelines, pharmacodynamics, and unit-specific protocols. I review updates from cardiology, attend pharmacist-led teaching sessions, and regularly discuss dose adjustments with the medical team to deepen my understanding. Each time I titrate a medication, I mentally link the action to the patient's hemodynamic response, reinforcing clinical reasoning. Overall, I maintain competency by staying curious, actively seeking learning opportunities, and ensuring that every clinical episode becomes a chance to refine my practice.